Good morning, Shelley.
Morning.
How are you?
Good. Did you want to present your screen?
Yes.
Let me stop here.
Good morning, Julia.
Good morning. How are you guys doing?
Good. How are you?
All right.
Good. Just so you guys are aware, Dr. Woolridge is going to be a little bit late today. He said he may be here at 8:30, but just with him leaving his shift and traveling, it may be a little late. Good morning, Jordana. Oh, I spoke too soon. Good morning, Dr. Woolridge. Dr. Woolridge, we did just hit 8:30. Did you want us to wait a couple more minutes for people to join, or we want to?
No, I think we're ready to go. I mean, anybody who joins later can always catch up where we're at. I think the premise to the meeting is clear to most in attendance. I see that welcome and introductions is, my name is there. So, but I think everybody's been working on this project. Is anyone new to this working group? In our meeting, I don't see everybody's name listed in the gallery. I see that we have 12 people. Is anybody new to our meeting? Just holler out, use your mic.
I see James C. on the call. I'm not sure who that may be.
Okay. Well, I guess all being said, children and youth with special healthcare needs is, I think, a training opportunity for our pre-hospital providers. And the effort of PACES, along with the Education Committee, chaired by Amber Rice, is working towards creating this module that can be taken out and used for that training purpose. This is our fourth meeting, and I went through all the slides recently, and I'm really impressed with the work that's been done so far. So I think as this is a fourth meeting and it's a progression from our last, we'll probably pick up, and Aubriana, correct me if I'm wrong, pick up at the slide we left off last time and move forward. Although I admit, and I will beg apologies to everybody, that I did go through all the slides again and noticed some or had some comments on previous ones. If there's time, if not, I'll send them to you separately, Aubriana. Aubriana, you're going to be running the slide deck, right? And then it's a free for all, and we just comment and we piecemeal as we go forward. Anybody else have any input as to how they thought the meeting ran well and strategies going forward?
No, I would just echo what you just said, Dr. Woolridge. I will say that there were some comments submitted before or in the interim of our prior meeting to this meeting for the slides that we've already reviewed. So if it's okay, I just like to go over those. And then, as you mentioned, maybe the ones that you wanted to discuss at a later time today.
That sounds great. And forgive me, but the browser I was using didn't allow me to insert comments just because I had to download the file when I was going through it. So if you don't mind, I'll just kind of verbally comment on the suggestions I had.
Yeah, I think that's great. Everyone has been having challenges with that, so it's not just you. So I will just move over. So if that's okay with you, Dr. Woolridge.
Yeah, I'm not the only one in the meeting though, so I want this to be a team effort. So I appreciate your deference to me, but anybody else have suggestions, shout them out, and let's start our work meeting. Okay.
Okay.
So Brianna, I think you're going to go through each slide, and then people will just comment as we go through.
Yes. Yep. So just to remind everyone, we had the learning objective slides put in from our last meeting. We all agreed on that. However, slide number 3 did have some different verbiage to include, thankfully to some of our members that attended. And they brought up a good point that ALS care provided by EMCTs for the scope of practice must be under the authority of the EMCT's administrative medical director. So we did change that from previously saying medical direction from a base hospital, as well as all EMCT providers. So these would be the 2 sentences that have been added or revised since our last meeting. And I just appreciate if we could get a couple of thumbs up to let us know that that's okay to move forward, or some verbal yeses as well. Awesome. Okay, thank you. So I will remove everything in red, and then we'll keep the bolding here just so that that's emphasized, but the red will be removed to black. Case scenario 1, we all agreed upon in the last meeting, as well as case scenario 2. However, there was some recommendations for case scenario 3 for some revisions to make a little bit more sense when reading it out loud. So yes, Dr. Woolridge.
Oh no, after you're finished with this slide, I have a comment. Okay,
excellent. So the scenario remained the same, but there was a proposal to change the case resolution, as you can see in red. So, and everything that was crossed out. So if I could just have everyone read it, and then we'll have a verbal discussion. And if anyone's okay with it, they can do thumbs up as well. Okay, thank you all. So I will remove everything that's strike through and change the red to black, and then that will be our new slide for case scenario 3. And then Dr.
Please, yeah. So I really like the case scenarios. I particularly like the fact that it illustrates, not, I wouldn't say mismanagement, but maybe improvements or errors that it could have occurred in the field that improvements could have had upon, and then the resolution is the appropriate outcome. In case, and this is probably just food for thought as we're moving forward. In case number 2, it does illustrate an issue and the appropriate resolution, but it doesn't illustrate maybe an error in the EMS approach like the other 2 do. And I think I need my EMS colleagues, paramedic colleagues, to help me on this one. If we were to illustrate maybe an inappropriate strategy that very often happens in the field, then it corrects to the appropriate resolution. Like, so for example, they identify it was dislodged, and EMS has a conversation with the guardians on replacement in the morning. Well, we know timely replacement is the best strategy, and then resolution would be prompt transport for G2 placement. But does that make sense? I mean, so I like this case scenario, but it doesn't illustrate an error in the field like the other 2 do. Resolution is perfect. Or am I being too critical?
I see we have some EMS people. So Jordana, Doug Costal, do you have any feedback? And Brian Smith as well.
So my understanding is that you want, sorry, I'm a little under the weather. So you're saying you want to have a not necessarily an issue, but something that can be rectified and kind of worked on from the EMS side?
Yeah, maybe an inappropriate or a less than ideal strategy in the field that is later corrected. So if you look at case 1 and 2, that's what they do. EMS arrives on scene, inappropriate strategy is taken, and then the resolution illustrates the appropriate strategy. So for example, if scenario number 1 says EMS arrives, but they didn't gather a history or consult with the caregiver regarding baseline vitals. The provider initiates standard protocols and separates the caregiver from the patient. That's the wrong approach. And then the resolution corrects the approach. So I really like that because it illustrates a common error in the field. Case 2 doesn't really have an error.
We could say that the crew decided to, have the family transport patient at their convenience, and that we can then say that's the wrong thing, that the patient needs to be transported immediately.
I like it. I think that sounds perfect. And then the case resolution identifies that prompt transport for prompt replacement is the appropriate processing.
I would also maybe say see if the parents have an extra G2 button or anything like that to be able to replace it to hold the stoma open. But that would be the parents doing if they are trained to do it, not EMS, because EMS is not trained on that.
Right. Yeah, no, I agree. And I think that happens a lot in the field. I just, since EMS is the audience to this slide deck, I don't want to somehow infer that they should be doing that. But I agree with your thought there.
One thing to note about transport is that state legislature actually prevents EMS from recommending the patient not to be transported. So I would be hesitant to put anything in here that suggests crews are telling the patient they shouldn't be transported at this time. It goes against state legislature. Do you have another suggestion for a possible error or poor plan that you're thinking of?
No, I have witnessed crews telling patients that they can transport themselves or to call somebody else to transport them or whatever, that they don't need to be transported emergently. So that was just my recommendation on it. I understand it's against state legislation, but it does happen.
Oh, it absolutely happens. I 100% believe you. I think maybe that could be part of our solution then is we provide that as the faulty strategy. And then in addition to the patient care aspect, we also note that that is an inappropriate strategy for managing transport. Does that make sense?
Yes, and then Alberta, can we maybe put in the legislation like link to just have that in the bottom of it as well?
Yeah, I can find it, and if there's a meeting chat, try to put it in the chat.
Thank you. And I apologize, Jordan. I know you're under the weather. I was not able to catch what we wanted to put in the scenario and the case resolution accurately. But the rest of the group be able to direct me so Jordana doesn't have to use all of her voice.
I would, if I might, second sentence, gauze was placed over the insertion site and the patient was promptly transported to the ED where a new G-tube was inserted by the ED physician, period. The patient was successfully discharged home to resume routine feeding.
Okay. And period.
Period, yes, yeah.
Thank you.
And again, second sentence, paragraph, gauze was placed over the insertion site and the patient was transported to ED promptly, period. Oh, no, I'm sorry. Second paragraph, second sentence.
Thank you. Yes. Okay.
Transported to the ED promptly.
Transfer to the ED promptly. Okay. Thank you. And then in the scenario, what was that sentence that we wanted to include?
Dr. Munn, I think that was you. I think it was to, goodness,
Jordana, I apologize. Would you be able to reiterate what you said? And I promise I won't ask you to speak too much more.
It's okay. Just that they were asked if the parents wanted to transport the patient instead of going EMS.
Okay.
Yeah. Well, I don't know if we should illustrate a parent error on this one, though. I would say, and forgive me, Jordan, I don't mean to step on your comment, but can we say that the EMS discussed either self-transport or replacement in the clinic? EMS discussed self-transport or replacement in the clinic, period.
Hi, Don.
Good morning. Just a thought on that, and I appreciate you, Dr. Woolridge, talking about like not wanting to highlight parent error, but I do think there's always opportunity for kind of that education. So I think to your point, you know, parents may sometimes be overwhelmed, and if this is a newer placed G-tube, it can be a little bit frightening. So I think crafting it in a way where the EMS can be a source of like education for the parents as well, and helping them kind of navigate that is always a good opportunity. So
I see that. I think Jordana was getting to that same thing too. So forgive me. Yep. How about EMS discussed with parents the benefit of prompt replacement versus versus delayed self-transport or delayed replacement in the clinic?
Does that look okay for you, Dawn and Jordana, and then EMS on the call as well?
I think if you phrase it that way, then you need to do away with the reference to 362219, because your initial one there is to have prompt replacement. So then in that case, they would be covering themselves under this new statute. So
I see. So in this language, EMS isn't violating that statute.
no, I don't. I think with the way it's phrased, they would not be. Or at least they'd be covered to some degree.
I like this. What do you guys think?
I saw a thumbs up from Dr. Munn. You as well, Dr. Woolridge. Just need one more thumbs up. Dawn, Adam, and Brian, and Jordana, thank you all. And Deb. Okay, excellent. So I'm just gonna preemptively move this so I can do that next time. Okay, and then when we're going through after the case scenarios, I don't believe there was any additional comments. Did anyone see anything on slides 7 through 14 that they wanted to discuss?
I have slide 12, please.
Okay.
So the last bullet, augmentative and alternative communication devices. And then the very last bullet says, what are they? How are they used? If that's a question, we should add a question mark. Or are we preferably making an actionable statement by saying, because I mean, if you look at all the previous portions to the side, it's more instructional, you know, avoid. So maybe that very last line should be understand what they are and how they are used. Something more actionable as opposed to a question.
Aubrey, this ties into the last slide about further considerations as for what we want to look at. This is towards that as well.
Yeah, that's a great point, Jordana. Thank you. So I think just emphasizing it here and then maybe having it in future considerations, that way they know to check on it twice, may be beneficial.
And then maybe some grammar on that last line. Understand what they are and how they are used.
Thank you. Apologize, I'm a little jet lagged today. Okay, excellent.
And then, yep, there you go. Sorry, I'm post overnight, so I'm being a little bit hyper vigilant, and I think that's keeping me awake.
No, that's great. Excellent. Is there any other revisions we would like to make to this slide? Or if not, just give a thumbs up. Jordana, Rachel, Brian, Dawn, Adam, and Dr. Woolridge. Okay, excellent. I will just highlight on slide 14. Jordana did add the emergency information form or sheet. That way EMS providers can be more familiar with what they're looking for when it comes to that go bag and that piece of paper for that pediatric patient. Is this okay for everyone within the work group? That this remains on there? Excellent. Thank you, Jordana, for adding that. It's a great addition. Okay, so this is where our work group session, if we have no other revisions to the slides 1 through 14, we'll pick up here, and attention to detail will be greatly appreciated in these slides. Okay, so starting with transport, did we see anything that we wanted to discuss during this segment? Yes, Dr. Woolridge.
I really like this slide. You know, restraining children who have skeletal deformities. One of the bigger emphasis that I make when educating about this is that particularly with spinal abnormalities, including the neck, what we call typical restraints can actually malalign and obstruct an airway. So actually mentioning the gravity of some of this. I mean, I like, forced strain or manipulate contractures. I mean, you can, risk fractures, you risk pain. But I mean, there's an airway issue here sometimes. So I'm almost wondering if we should actually have a bullet that says, that emphasizes that, because that's, I think it elevates the significance of this, or the importance. I don't know what I should have wordsmithed it better, but that was just my thought about this slide. So how about typical restraint positions could run the risk of airway malocclusion?
Okay, and then Dr. Munn also put in spinal, and that anatomy may prevent lying flat, and attempting to overcome this may cause airway compromise.
Just a wording suggestion, you use whatever sentence you'd like. I would suggest we pull that bullet back one tab because it's currently under the extremities. Does that make sense? Yes, thank you.
Rachel, I like your way of phrasing it a little bit better. Do you mind saying it one more time? I'm not seeing my chat.
I just put it in, Dr. Ulrich.
Oh, okay.
I liked both, so whatever the group prefers.
I like Rachel's.
I like the simple language.
Okay. Thank you guys for that feedback. Does this look okay for everyone? If so, can I get 3 or maybe 4 thumbs up? Jordana, Brian, Rachel, Dr. Woolridge, Doug, thank you all. Oh my goodness, so many. Thank you. All right, so next is facility selection. Just give everyone a couple moments to review this.
Oh, but did we want to put in the safe transport guidelines? Or either the slide before or this one?
We could do safe transport. So like the EMSC Innovation and Improvement Center has linkage to the safe transport guidelines. I would potentially recommend leaving that till the end, just because I know they're continually changing, and I would hate for them to click into here and not get access to it. Whereas if it's a resource, we know that sometimes those can change.
This might be very picky. Do we want to say any and all emergency departments should be able to stabilize a pediatric patient rather than hospitals?
I would agree with that, yes. Thank you, Dr. Lynn. Okay. Not hearing anything else, so if everyone's okay, if I could just get a couple of thumbs up. Hello, Dr. Woolridge, Brian, Dr. Munn, John, and I believe Jordana. Thank you. And Doug, thank you. Okay, so equipment. Let's give a couple minutes for this, or moments. Is Dr. Woolridge? Oh, you're on mute.
The Pediatric Assessment Triangle, PAT, will all of our audience know what that acronym stands for? Or should that be spelled out?
I think that should be spelled out. Thank you.
maybe next line for the definition of appearance.
I'm going to do that for this as well, if that's okay.
I don't know how I'd like to suggest to reword it, but under allow the healthcare provider, sorry, I think I can highlight it. Yeah, I think we should reword may have consequences to something else. Perhaps maybe to say is not recommended or is not. I don't know. I need a little bit of help. or that might be good. I don't know.
How about may worsen condition? May worsen the condition.
Yeah, I like that terminology a little bit better.
Thank you, Adam.
Yeah, thanks.
Maybe suggestion would be not in our scope of practice.
Okay. Sure. And may not be in the scope of practice, or just put.
Well, removing or messing with these devices really is in our scope of practice. So we're identifying what our supportive care could be, that removing these devices isn't in our scope of practice.
Okay.
I guess that's kind of what I was getting at, Doug, was are we allowed to?
How about
the terminology of like may have consequences suggests you can still do it. You just have to be careful with it versus can you or can't you, I guess was my point.
Yeah.
Sorry.
Correct. And then just providing supportive care.
I would say may not be in the scope of practice
Mm.
instead of is, just because
Mm-hmm.
accessing central lines can be, and it can be trained. So I think may is just a little bit more flexible.
That's good. Yep.
And then I saw Brian raise his hand next, and then Jordana after that.
I think that was the purpose of me requesting that first statement about scope of practice, because otherwise you could write the same thing dozens of times in this presentation if you were going to try to cover that everywhere. That was what I was trying to get at with that slide back at the beginning about scope of practice, so that it covers everything in here.
That's a good point, Brian. So did we want to just go under the premonition that people understand through their scope of practice what is allowed, or by having that slide at the beginning, or do we want to continue to emphasize it throughout the slides?
I found another one that we had done earlier. I don't remember which one it was I was looking at the other day, that has a general disclaimer at the beginning about scope of practice, so that you don't have to go write every what's BLS, what's ALS, what's in the scope of practice everywhere in the document. So
Brian, you bring up a good point. Just absolutely would be writing that in everyone.
Okay. Thank you, Brian and Doug. Jordana, I see your hands raised.
Just trying to look at this sentence of how it's worded. It says allow the healthcare provider or guardian. So he's saying to assist you by disconnecting or discontinuing any of the devices. You're saying that the parents, guardians, whoever's the caretaker of that patient in their home could possibly do this, but you cannot. So I think that's where we're getting a little bit of the confusion, is that first sentence kind of doesn't end well, and it kind of goes into the next statement wrong. Does that make sense?
Yeah, it does.
I do see that, Jordana. That does make sense actually. Yeah, and then in that case, I also then agree with Brian. I think we can not reference scope of practice since we are setting the person up to be working with the guardian in this particular position.
Okay.
Yeah.
So
Yeah, so,
I'm so sorry, Adam. What were you
no,
doing?
that's what I had to say. Thank you.
Thank you. Thank you both, Jordan and Adam. So I had originally removed the wording that we were going to say instead of consequences. Is there, what was the other verbiage we'd like to use? Dr. Woolridge, you had a good few words.
I think it was may worsen condition.
May worsen condition. Thank you.
Yeah, me.
Sorry, I might have just ran us around for nothing.
No, not at all.
I like that.
Excellent. If there's no other further revisions, if I could get some thumbs up, please. So Jordana, Adam, Brian, Don, thank you, Doug, Dr. Woolridge, and I think Dr. Munn too. So thank you all. Okay, so tracheostomy tube has a couple slides. So we'll start off with slide 18. Anything we want to review or revise on this?
So I had a comment for this. So the slide 18 through 22 is all about the tracheostomy and like the care and how to do it and everything, which doesn't really fall in the scope of practice of EMTs. Did we want to maybe condense this and make it a little bit more, these are the things that you can incorporate or let it come in contact with, here's how you should address it, and make sure the family is aware, and then just take all the equipment with you. And then maybe put in the little training deck slide that ADHS has already in place with a link or QR code.
Thank you, Jordana. I'm going to have Dr. Munn go and then.
Thanks. Sorry, I wasn't raising my hand earlier. I was being very rude. I do. So the tracheostomy management is in paramedic scope of practice. So I don't know exactly how much I would condense. I think it's an important topic. For the first sentence on this slide, I think it seems a bit redundant. I think we could condense it to tracheostomy problems, or tracheostomies have a high risk of airway compromise and resultant hypoxia. I think we have it's just longer than maybe it needs to be. So we have like the most serious complications are related to tracheostomies have a high risk of. So I think we can just axe the whole first little bit there if other people agree.
And Jordana, to your point too, regarding the tracheostomy training we do have, I believe Brian also recommended just having that reverted back to. So I did put that down in the resources. That way they get that additional training as well. That's already been completed. And I know there will be a lot more discussion when we get to 21 and 22. Okay. Is there any verbiage that we want to change out of here, or are we okay with the slides?
If I may, the last bullet point, I agree with the information there, but I'm wondering if does it belong on this slide? Because we are giving a very general overview in the first two bullets about the types of problems, but then we move right on into managing one of the problems without any intro to that. So I don't know if it fits better on one of the other slides.
I would agree with that. Yeah, I can remove this part if that's okay with everyone. Jordana, Doug, Donald. Okay. So I think it may be better here. Great. Or it says it here as well, I believe, just in a more concise format.
It does. I think that's perfectly fine there.
Is there anything we want to change about the title, or is everything okay for this one? We'll just keep it consistent with tracheostomy too. Okay, hearing none. So if I can get a couple of thumbs up and we'll move to the next slide. Okay. Excellent. Okay, so ventilator troubleshooting. I realize that this may be out of scope of practice for a lot of our providers. So I'd look forward to any feedback or discussion we can have regarding this. But I believe this is just the introductory slide. So if you want to just review this real quickly, and then 21 and 22 should be good discussion. Okay, Dr. Nunn, I see a thumbs up. Dr. Woolridge. Yes, Brian?
So I don't remember the next slide. Would it be appropriate to go ahead and put dope in here with the explanations of what that is, if it's not on the next slide?
Yeah, I don't know if I kept dope in here. I didn't. Yeah, so
I don't think we did.
nope, I took it out.
Well, there's actually another place that had dope in it related to like central lines and stuff, and one of them didn't make any sense, and I couldn't find any support for that, but it certainly is appropriate for ventilator management.
Okay. Did
But
they want
if it's covered individually somewhere else where it's getting all the topics, that's fine.
so
I think it was good. Sorry.
no, you go, Dr. Woolridge, you go ahead.
Yeah, no, I'm not raising my hand either. I'm sorry for that. I think it would go well here, and maybe as an appearance, maybe even having it as a separate separate box that's colored a little bit differently, just for appearance sake, but having dope outlined, and then defining what dope is: dislodged, obstructed, blah blah blah.
And then I think I saw Keena's name here. Hello, Keena. Keena says, I think there's a standard knowledge of dope for paramedics as well.
I think we need to do it for the other BLS providers, though. They may or may not know it.
Okay, so I will add a new slide then, just so that it has its own separate one. Is that what I'm understanding?
No, I was thinking about it, just a bullet that's behind it. I'm sorry. It probably is beyond our conversation here. It's just more of appearance. Sometimes you have its own little, bubble where it's color coded a little bit differently at the bottom of the slide. But having it here is my main point. So
Okay. Okay, excellent. So I will, goodness. I will do that, and I can send that individual slide to everyone if you want to review it after and let me know it's okay. That's allowed. Okay, and then are we okay with the remaining of the slide and we're okay to move forward to the next one? Okay, seeing thumbs. Thank you. Okay. So Dr. Bradley had some feedback on this as well as Dr. Munn. So Dr. Munn, if you just want to reiterate your point for this slide, that would be greatly appreciated.
So when you're looking, I know we've had some scope of practice discussion and training discussion, but currently for non-critical care medics, automated transport ventilators are the only type within scope, and those are relatively simple devices that may be more so than what patients are using at home. I don't think it's a terrible idea to provide some introduction to ventilators, but I want to be careful that we're not asking providers or presenting the expectation that ventilator troubleshooting and kind of managing the patient's home ventilator are expectations out of this training. Does that make sense?
Yes, and I believe it ties into Jordana's point that there may be a significant amount of information and maybe condensing, but I don't want to speak for Jordana. Do you find that this would be relevant for the EMS provider to know from your experience of both lived and professional?
I'm sorry, I'm like struggling.
I'm so sorry.
Yeah, I agree. It's plain and simple.
Okay. Thank you, Jordana. And Brian, I'm going to move it over to you, and Jordana, I'll chat you and relay all your sentiments if that's okay.
Could you go back to the previous slide real quick for me, please?
Yes.
It would seem prudent perhaps, and maybe on that next page where it talks about, treating the patient and not the device is, and it could also go here with dope, is that the patient should be being bagged while that's the appropriate care is to immediately switch to a BVM while you're trying to sort that out. At least my understanding of where that would go.
Any comments from the group?
No, I agree with that sentiment. If there's any concern for ventilator malfunction, I think switching to utilizing a bag is the absolute correct choice.
Okay.
And that falls in with our scenarios as well.
I accidentally cut you off, Jordana. I'm sorry. Did the rest of the group hear her say that that will tie into the scenarios as well? Is that what I hear? Okay, awesome. Thank you. So from my understanding, maybe just remove this slide entirely then, and then we'll just prioritize the scenario and then this slide as well, but remove this one.
I like the sentiment where, it says examine the patient. If you have no respiratory distress, everything is normal. Say they're for a non-respiratory condition, you can absolutely transport them on their ventilator, I think. So I like some of the sentiments in this slide. I think maybe going over ventilator alarms is where we get into over information, but I'm very open to others' opinions on that.
I like this slide because the way I perceive it is it's giving me some ideas of why the machine is alarming, and some of these do seem like some simple fixes. And I look at the simple fixes before I go to the extreme.
Thank you, Doug. And Dr. Munn, is there any additional feedback from the group, especially EMS? Hello, James C.
Hi, I agree with Doug with respect to having the table there because it's a very good reminder of some things to kind of take a look at before we start disconnecting the web. I think the other interesting piece is that
James, I think you either froze or your volume cut out. You'll pause on James, and Allison, I see your hand is up as well. And then we'll come back to James. He's having tech issues.
I just had a small wording suggestion, which is I think we should replace the acronym SHN with child in both of those cases. I think it's fine for the group, but somehow looks a little dehumanizing. Yeah, like when we're talking about the individual.
Or maybe patient instead of child.
Sorry, Jordana. Okay, I spoke of you. Go ahead.
No, patient is what I was saying. You're good.
Yeah, I think that sounds, that sounds good. Thank you.
Thank you. And James, is your tech working by any chance? Okay. All right, still working on it. Thank you. So while we want to just come back to this slide for when James's tech is working, and then we can revisit, or okay, or we can continue. It sounded like there was potential support for this, so maybe we keep this so that EMS providers know what's going on. But do we want to emphasize that it's not in scope of practice, or?
I would probably refer back to Brian's comment, is that, that was at the beginning of the slides in the presentation that said to remain in our scope of practice. So that's my opinion.
Thank you, Doug. My apologies, Brian. I should have kept that in mind. Thank you.
I don't think any of the interventions proposed here are unreasonable. I'm okay with it as is, and this will go through the education committee also, correct?
Yes.
So we may get some comments from them, but I feel like at this juncture, I would move on.
Okay. Thank you. Okay. So on to the next set of ventilator troubleshooting. I saw that there were some comments regarding this. Is there any questions? Yes, Dr. Woolridge?
Yeah, the thing that jumped out at me was lower down in the slide, it says to prepare for a thoracotomy. And we're having a lot of conversations about scope of practice. And do we want to instruct people to routinely consider a thoracotomy, which is an open procedure, not just a needle decompression?
I think yes, Brian.
I was going to suggest needle decompression, but I got beat to it.
I think Dr. Bradley beat you both to it. She had mentioned needle decompression as well. So I will put needle decompression in here. And does that verbiage work for everyone? Okay. Yes. Okay. Is there anything else that you'd like to revise from this slide? Oh, yes, sorry. Thank you, Allison. So we're going to remove SHN and we're going to replace it with patient. And I'll be sure to do that for the previous slides as well. Thank you, Allison. Yes, Dr.
With regards to the needle decompression, we could expand that sentence slightly and say absent unilateral breath sounds and concern for tension pneumothorax. I think most protocols have just a little bit more in them than just unilateral breath sounds, because I don't think we'd probably recommend doing this on an asymptomatic patient who just happens to have no breath sounds, especially considering some, as we teach in other slides, exams may be normally abnormal. So we could expand that.
Yeah, I like that, Rachel. If there's no hypotension or hypoperfusion, it doesn't necessitate an intervention nearly as much.
Okay, I tried to document that. Does that sentence look better?
I like it.
Thank you, guys. Okay. And if that works for everyone, I'll just see a couple of thumbs up and we'll move to the next slide. Okay, awesome. Thank you. Okay, so indwelling lines and ports. Jordana, I will say she did add a link in here so that they could go over to the sepsis resource that we have on the EMSC national website. But is there any additional conversation around this slide?
Do we want to mention anything about not every emergency room is going to be able to handle this, that it is a specialty and will need to be seen as such, and to take that into consideration for transport?
Sorry, guys, I'm just. Is that same sentence okay to be put here as well, or do you want it more condensed?
I think that works.
Thank you, Jordan, for that. Okay. Organization-wise, I would just like to move this maybe into the resources section. Or we can keep it here and then maybe just put it under this sentence. What would people like? Yes, Tom?
Not related to the formatting. I have a question at the risk of sounding a bit ignorant, a non-EMS person here. When we put this disclaimer about, you know, while all emergency departments should be able to stabilize, but, you know, some may not have the ability or specialize, is there a way for the EMS providers to know what hospitals are capable for specialized? So I think putting the disclaimer is good, but I was just curious about then what? Like, do they have a way of knowing to help in deciding in transport? Or are we just putting that out there, and who's going to help decide which facility to go to is basically my question.
Thank you, Dawn. Dr. Woolridge?
Well, I could comment to that, but I'm sure there's people at the table here that have more authority for that. But yeah, to answer your question, Dawn, for this to recommend or delegate, typical, types of transfers or where to transfer probably is beyond the scope of this, because this is going to go to all communities. But the answer to your question is yes. Each EMS agency does know the resources and the attributes of the facilities they transfer to. Similarly, the guardian is going to have a large influence as to where the patient is ultimately going.
Okay, perfect. That's helpful. And the reason I'm asking is I do some other project work with Phoenix Children's in some other areas. And there's been discussion for some of these very complex patients on revamping like discharge instructions. And so I was thinking it would also be helpful for the families for the discharge to have something in there about if issues with this, come back to this facility, or, especially if they are not in like an easy location, if that makes sense. So I just wondered if that would also be helpful, so the guardians have some insight on how to navigate that as well.
That's a great point, and that might be something, Dawn, for EMS for children to focus on, maybe with the hospitals. And I appreciate you bringing it up.
Thanks.
And Ariana, to your resources question, but jumping back to that, I would vote to put some line here that gives a little bit of like context and includes that hyperlink, like whatever. I don't know exactly what that resource is going to, but like for more information about blah, 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 like see this. And I think you can put it at the bottom of this slide, but then I would also include it in that overall resources list if you have an overall resources list.
Okay.
But I think sometimes it's easy to have things like right at the fingertips of where someone would need, and to give them that little bit of instruction about what they're getting from that link.
Okay, excellent. Thank you, Alice. Yes, Dr. Moon?
Just to bounce back really quickly to the transport discussion we were having. We may have addressed this in one of the slides previously, so please correct me if we did. But I think the point of this kind of caveat statement we're making is to remind providers that if you have a critically ill patient, so someone who needs immediate airway intervention, who is hypotensive and you have no access and you need immediate resuscitation, that stopping at the closest emergency department can allow that patient to be stabilized. But if you have a patient who isn't critically ill, that's when a lot of these transport guidelines, specialty hospitals, things like that come more into play. And I feel like that's a lot of nuance, and I'm not sure how best to kind of communicate that message in this training.
Thank you, Dr. Moon. And Brian, I see your hands up, and then Dr. Woolridge after that.
Yeah, I agree with an earlier statement from Dr. Woolridge. I think that's kind of getting out of the bounds of what we're trying to accomplish. So AIMS might have some designations on different hospitals set up in their red book, but most of the rest of the state doesn't necessarily determine that everybody is going to have some particular piece of equipment to take care of these patients. And a big portion of the state's going to go to the closest facility no matter what.
Okay. Dr. Woolridge, you had your hand up, and then Dawn after that.
Yeah, I was just going to comment in the same line that Brian just did. Each agency has their own internal guidelines and policies that they approach which takes all of what we've been saying in consideration. So I think we're outside of our purview if we start trying to delegate that.
Thank you, Dr. Woolridge. And then Dawn?
So hearing that, understanding and respecting that, I do want to say, I think the point of this training and curriculum is to help expand the considerations and comfort and knowledge of EMS in working with families that have very complex medical needs, and how we can best address the care that can work in the best manner for the patient and the family. So I go back to understanding, like, this may be out of purview, but I think there needs to be the thought process of, if you're coming into this situation and this family has specialized equipment or certain things, that it can't always necessarily be in the best interest of the patient and family to just go to the nearest if they don't have the capability, because then you're having the compounded issue of, then you get to that facility, the family is in an unfamiliar who can't treat their child, and then we have to worry about and figure out additional transport if that doesn't. And so I go back to the possibility of, if the family has guidance from a care plan or discharge instructions of what, coming back to their specific facility or specialized hospital, that we just allow the EMS team coming in to know that there may be those other alternatives and why. So I think we're trying to expand the comfort of EMS to work with the patient and family with some of these more complex, and not get held up by, like, this is what we do all the time, no matter what, because it ultimately doesn't work well for the family and the patient sometimes. And I just want to make sure we're being thoughtful in this curriculum of the real purpose of it is to help expand comfort and care of this population to the best outcome for the patient and family as well.
Thank you, Dawn. That was a great point. I appreciate you elaborating on that. I did put another sentence in there if we want to review that. And Kina, I see your hand is up as well.
Hi, I just wanted to add on to what Dawn was saying. Generally, when EMS responds, they do take patients to the requested hospitals, especially if that's something that the parents already know. In an emergent situation where a patient is critical and needs immediate stabilization, though, they will transport to the nearest capable facility for stabilization. At that point, it's up to the hospital and the parents and everything else. The hospital facilitates it, actually setting up the next transport to the appropriate endpoint. But that generally we would transport to where the family would need to go or prefer to go, unless it needed immediate stabilization.
Thank you, Kina, for that. Okay, so with all that great discussion, did we want to just put in here just a disclaimer that if it's not a non-emergent situation, that families have care plans for preferred destination? Okay. And Dawn, does that work okay for you as well? And Jordana, I saw Jordana's thumb go up. Okay, excellent. So with that, is everyone okay with this slide and we can move on to the next one? Jordana, I see a thumbs up. Adam, Dr. Munn, Dawn. Yes, Dr. Woolridge?
Yeah, I'm totally fine with the edit. But we pulled this this paragraph here from another slide.
Yes.
So if we adjust it here, we can adjust it in the other instances too.
Yeah, that's a great point.
Okay. Right.
Mhm.
Fair enough.
Thank you. And we'll add that here. Thank you, Kina. I appreciate your time today. Excellent. All right, so we're all set with that. So next is the indwelling lines. There was a question about padded clamps. Dr. Bradley was just recommending that maybe we remove that. So is that okay with the group or?
I agree. I'm not super sure what a padded clamp refers to specifically.
Okay, so
I think primarily it's so that the teething on the clamp doesn't damage the rubber of the line itself. It's not a serrated clamp.
so maybe I should put non-serrated clamp or do we
I
not?
think my counterpoint would be that if the line is lacerated, it's damaged and is going to need to be replaced anyway.
Right. Just clamp it. Yeah.
I think your pre-hospital supplies might be limited, so I don't know if specifying a specific type of clamp would be fruitful.
Okay, so we'll just say to laceration then.
Looks good.
Okay, thank you. And then Brian, I saw your hand was up.
It was covered. Thank you.
Thank you. Okay, thank you, Dr. Moon, for that. And then also Dr. Woolridge, I do see your hands up.
The terminology, the second line, it says check for blockage of the line. I think that can be interpreted in a couple of ways. Are they just looking to see if there's any mechanical disruption, or are they literally breaking the line, entering it, and flushing it? And there are some specialty lines that we don't want tampered with, particularly hemodialysis catheters, some of these TPN-related solutions. So I'm wondering if we can clarify what the team means by checking for blockage. Are we just looking for mechanical damage or mechanical obstruction?
That's a great question, Dr. Woolridge. I see Brian.
Yeah, I mean, there are going to be people who can access central lines that may know how to deal with that if they've been trained, because it's an STR, they may know how to deal with that, but a lot of people aren't. So let me think. I think kinking and things like that might be more appropriate to look at initially than trying to determine if it's internally blocked.
Yeah. Yeah, I think that phraseology, Brian, would be better. I mean, if someone tells me to check if it's blocked, I'm gonna try to flush it. So, and I don't think that's what we want people to do in the field on all these cases.
Right.
Yeah.
Does external blockage work, or do we want to put kinking in there?
For me, it's just checking for damage. Checking for damage leaking from the line.
Okay. Excellent. I see some thumbs up from Jordana and Dr. Munn. Thank you. And thank you, Dr. Woolridge, for that. Is there anything else we would like to address on this slide? Yes. Yes, Brian? Oh, Brian, I saw your hand was raised.
Oh, sorry, muted myself. I think if you're going to do it that way, that second bullet point should probably just go away.
Okay.
The main bullet point, if the line is blocked.
Okay.
Yeah.
Okay, I see thumbs up from Dr. Munn for that. And then Jordana, I saw your hand was raised.
I was going to say the same thing to remove that line, so that's fine.
Okay. Thank you, Jordana. Yes, Dr. Woolridge?
Where your cursor is, if the line is damaged or lacerated.
Okay. Excellent.
Uh,
I-
Yeah, and then it goes on to say clamp proximal to laceration. It says laceration, and so clamp proximal to defect.
Okay.
I'm more than willing to have someone correct me on my language.
Okay, thank you, Dr. Woolridge. And Brian, I'm gonna move over to you.
Yeah, I think you should still have a reference to kinking, check for damage, comma, kinking. Because if it's kinked, those can frequently be easily resolved without having to clamp, just automatically clamp proximal to it. And then we could have a line in there to straighten kinking if possible, something like that, and minor bullet point or whatever.
Okay. Yes, Dr. Munn?
Could we say, or should we add under apply direct pressure to the skin if bleeding? Because otherwise, I don't know if we need to just apply direct pressure just because the line has partially pulled out.
Okay. That works for me. And then under the kinking, Brian, you said you wanted an additional line to tell them to straighten it out. Is that what I heard?
I guess if line is damaged or lacerated, clamp proximal to the defect, and then you could have another line that said if line is kinked, attempt to straighten kinking if possible.
Okay.
So, and just some of the, so I'm sorry, once again, I did not raise my hand. I apologize. If line is out or partially out, and then the next bullet says, do not push the line back in. So that's in direct relation, but then the subsequent bullets are not necessarily in direct relation of being partially out. Applying direct pressure, if it's bleeding, it may or may not be out. So why is it a sub bullet? Yes, definitely stop infusions. I'm just thinking about the order and the indents of the bullets. One thing I do suggest sometimes is to apply an occlusive dressing.
Okay. And then are you recommending that we remove this, the apply direct pressure to skin site if bleeding? And then
Yeah, and please, people, tell me if I'm going in the wrong direction. But what you have highlighted there, I don't think should be indented under the partially out statement. So I would tab that back out to the left.
Okay.
And then I would say, if bleeding, apply direct pressure, and that's a standalone bullet.
Okay. And then I'll remove all of the other ones. So apply occlusive dressing is for partially out.
That would be for partially out, yes.
Okay. And then stop any infusions as well.
Yeah, if it's partially out, definitely stop infusions. Yeah, I like that. I like that.
Okay. And then always bring line with you to the hospital if line is partially out. Okay.
What do you guys' thought about that restructuring?
I see Brian, thumbs up. Jordana as well. Adam, Doug, Dr. Munn. Okay. Great. So that's good. I'm just going to move to the next line if that's okay. Or next slide. Okay. Awesome. Okay, so feeding tubes, there's not much wordage on this. It's more within the speaking slides. I don't know if people got a chance to look at those. Do we want to do anything to the slide? Keep it?
Well, we don't really have any text on instructions to the pre-hospital provider on what to do with the feeding tubes. We have case scenario number 2.
Yeah.
So do we want an accompanying slide to go with this that actually offers some directions?
So maybe I take all of this verbiage out and then put it in a separate slide. Or, I mean, this just kind of still goes over what it is, what a feeding tube is. What does the group think?
I'm pausing because I want others' opinion.
Yeah.
I think it's a nice FYI, but again, I don't know that we're providing a whole lot of instruction. So I would also be curious as to others' perspectives.
Thank you, Dr. Munn. Jordana, I see your hand was raised as well.
Would it be beneficial to move this slide by the case scenario so that they can see for it? And then the talking points, I think it is pertinent to just say that the stoma is closed quickly and that not all patients will be, or most patients will be NPO, but not all. And aspiration precautions should be considered. Those 2 little bullet points right there, I think are important for the EMS providers to realize.
Okay. Thank you, Jordana. I think that's a good point. I think for flow-wise, feeding tubes with a case scenario might be beneficial.
Well, the image on the right is already embedded with case 2. So the image on the left is the only one that's new.
Okay.
So you can keep the image on the left on this slide and include those text elements that Jordana just commented on.
Okay.
Regarding comments on the previous slide for a dislodged central line, I would argue the same, tape it in place, occlusive dressing, bring it with you. Those are the same bullet elements.
Okay. Okay. I will fix these to be bullet points after, but for the interest of time, is everyone okay with the slide, or is there anything additional that we would like discussed about it?
The feeding tubes, if you have just the NG tube here, that goes through the nose. And so that's not a stoma. So that's not going to benefit your bullet point of saying stoma's closed fairly quickly, just because it doesn't correspond with your imaging.
Okay. Thank you, Jordana. So maybe we put the G tube one back in, just something for the group to think about while Brian, your hand is raised.
Yeah, on that 3rd bullet point down there about G tubes, the family usually have a backup replacement tube. I think that next line, if a Foley tube can, if not a Foley tube can be used. And I don't know that this is more important that it seems to me like it's covered. If it's been dislodged, that it's covered. It's not. I don't think it's necessary that I'm aware of that it needs to be held open by something. And I think that since some EMS units may have Foley catheters, they might be inclined to go ahead and do that. And I don't, unless somebody has some other thought, I don't think it's necessary.
Okay. Thank you, Brian. Dawn, I see your hand is raised, and then Jordana.
Just a quick question, Brian, when you say, can you help me understand when you say you don't think it's necessary to have something in there to hold it open?
No, if it's dislodged, then it's going to need to have things done to it at the hospital, and I don't think this is the kind of thing that EMS really needs to be attempting to do in the field. It's going to need whatever corrections it needs at the hospital in order to resolve getting it back in.
Okay, I'll just add just for some consideration. So we're instructed to like sometimes the hospital will give us things and instructed to insert to keep it from closing because of how fast it can close to get before we do get to the hospital. Because if it does close, then we're looking at like far more invasive for correction. So I appreciate that what you're saying, but I'm wondering if there's any opportunity to address that. And I'll let Jordana also kind of chime in on that too. So
yes, so parents will have a backup supply of either another G-tube button or a Foley tube to be able to insert from their home care supplies or whatever they have. So I would instruct parents to, if they haven't, to put something in there to hold it open. If not, they also have there's a little device inside the G-tube replacement kits that come with the G-tube buttons to hold it open, specifically because the stomas do close. And if we don't get it replaced quickly enough, we will have to go back in and have actual surgery with sedation and other things. And that is more of a detriment to the patient than anything.
Thank you, Jordana and Don, for that, and Brian. I believe Dr. Woolridge's hand was up, and then Brian after that.
Yeah, and I might be stepping on Brian's toes here, but I'm in 100% agreement. Although that being said, I don't think the EMS personnel in the field are essentially allowed to do that. So this kind of falls into kind of our previous slides of encouraging and allowing the guardians to do what they know they're supposed to do, which is to make efforts to keep the stoma open. But then once they get to the ED, we very often will radiographically confirm placement particularly if it's a J2, because those are much more tenuous. But so 100% agree, got to keep that stoma open. If parents aren't able to recannulate, then it's hurry, get to the hospital so you can get one in. But I think what Brian was saying is I don't think EMS is allowed to do that. Brian, you have your hand up, so maybe you can clarify.
Yeah, that's the main issue. That's not in the scope of practice to be doing that. I just want to make it, if it needs to be open and the caregivers or family can do that, that's fine. But I don't think EMS has anything in their scope of practice that says they could do that.
Okay, excellent. Thank you guys for that robust discussion. I did put by the family caregiver to try to eliminate EMS doing it. Does that work for everyone? Jordana, Dr. Woolridge, yes. Brian as well. Thank you, and Dr. Munn. Okay, great. Well, this has been a great amount of discussion today. Dr. Woolridge, I'm going to circle it back to you because I don't believe we're going to finish in the next 5 minutes.
I've been up all night. Don't do that to me, Aubriana. I'm really pleased, and I think this team is working really well together. So I really appreciate everybody's input. So I think this is really getting close, and we only have like 8 more slides. So I'm almost willing to just say, hey, let's push through. But I know we're at the end of our time. Sorry, Aubriana, do you think one more meeting is going to be able to do it, or?
I mean, I'm happy to push through today if everyone has availability, but we could do it in one more meeting as well. Probably be an hour. Ideally before July 10th so that we can this to the committees and not have to wait until our meeting in November. What does the group think? Stay today and another meeting. One more meeting, Dawn. Okay. Okay. Well, to be respectful of everyone's, I'm happy to stay, but we'll also attempt to attend one more meeting if scheduled. Okay. Doug, is that a thumbs up for staying or another meeting?
I'm here for whatever the group decides.
Okay. Okay, Allison can go either way. Brian's good either way.
I can stay, Aubriana. If the group decides to stay on, I'll stay.
Thank you, Adam. Either, okay. I believe that's James C. Are you able to stay? A thumbs up as well. So the majority can stay. So I think if we can just push through today, that way it's good for July 10th. Let's just try to do that. It shouldn't take much longer. Probably another hour at most. But so outside of this, is there anything? Thank you guys for being flexible. I'm going to add the G2 picture back onto this slide as well. Is there anything else? And then Dawn has to jump off at 10:15, so we'll move quickly. Thank you, Dawn, for staying extra. But is there anything else we want touched upon this slide besides adding the additional photo? Hearing none, can I get a thumbs up to move to the next slide? Brian, Doug, Dr. Woolridge, Adam, Dawn. Thank you all. Okay, so cerebrospinal fluid shunt. I think Adam should speak about it because his initials are in the picture. But I only
I did not have edits on this one.
Okay, thank you. Is there any edits from the group? If not, just give a thumbs up and we'll move to the next one. Okay, thank you. Okay, so second slide for cerebral fluid shunt. Hearing, yep, yes, Dr. Lund.
Do we think it might be slightly redundant to say if no pulse, begin chest compressions? I feel like that's fairly self-explanatory and just kind of adds text.
That makes sense. So maybe I'll just remove that. Okay. Thank you, Dr. Munn. And Adam and Doug for agreeing. Do we need to spell out ICP for anyone or?
I think that's pretty common knowledge.
Okay.
I might suggest spelling it out.
Okay. Because I am non-EMS, would somebody please tell me what that acronym stands for?
Intracranial pressure.
Thank you. Okay. Thank you, Allison. I shared the same sentiment. Excellent. Is there anything else we want to add to this? Dr. Munn's good. Doug is good. I just need 2 more thumbs up and we can move to the next slide. Dr. Woolridge and Jordana and Brian, thank you. Okay, so urinary catheters. I believe this was an STR scale, so there's some discussion about this. Dr. Munn mentioned Foley catheter insertion is a skill that requires special training. Providers may or may not have received this, so maybe hesitate including instructions to flush a Foley catheter. Dr. Bradley does agree with that. What does the remaining remainder of the group think? Jordana agrees with that as well. Doug agrees with that. Adam and Dr. Woolridge as well. Okay, so where would you guys like me to remove stuff? Just so that I make sure I'm not removing anything improper. Yes, Dr. Lim?
I don't see anything in here that needs to be removed. This kind of like with our NG tube, it is an FYI slide, but it doesn't provide any instructions that I think are inappropriate at all. So I think it's great.
Thank you, Dr. Lim.
Yeah, I agree. This is informational. So we're not talking about or suggesting interventions. So I think it's good.
Thank you. Okay, excellent. So if I can get a couple thumbs to move to the next slide. Okay, awesome. All right, so we have neurodiverse children. This is one of 3 slides. It was proposed that we condense them, but Dr. Woolridge, I will.
Just a quick typo. Low down, it's not stemming, it's stimming with an I.
Oh, thank you. Okay. I see Doug has a thumbs up. Looks good for Doug. Looks good for Dr. Woolridge. James C. Brian, yes, Dr. Mum?
Is stimming a common enough term that we feel it will be widely understood?
Very good point. I don't think so. This is a point of acquiring stimulation, in parentheses, stimming. I mean, that's all it's referring to. I don't want to say the word self-stimulation because that may have other connotations, but
does that work or no?
actually acquiring may not be the right word. Individual stimulation or I don't know, help me here.
No, I was trying to think because I agree with you. I've always found the self-stimulation sounds very odd. Like seeking stimulation maybe or something like that. Like,
okay.
I don't know. Again, if anyone else has better ideas, like so, I don't know.
Or how about just no word there and this is a form of stimulation.
Yeah, yeah.
Thank you both. Jordan, I saw your hand up, and then Dawn.
It's okay.
Okay.
Or how about this is a form of individualized stimulation because each kiddo does kind of their own thing.
It's redirecting input that they're receiving. So it helps to redirect that stimulation is redirecting input neurons so that they can not be overloaded with what's going on. They're trying to calm down stimulations.
Okay. Redirecting input.
I know, Jordan, I wondered about using that word like self-soothing or calming or something, again, to just kind of like explain like what is the purpose of this, but I don't know if you can think of like a better way to say that.
And then I want to be respectful of Dawn. Dawn, you have your hand raised.
Yeah, I think I just wanted to note, like sometimes this stimming can also be like flailing of hands or other type of motions that I think could be misconstrued as like combative behavior. So I would also really I think highlighting this is important because there needs to be an understanding that, you know, what they're doing could be the stimming and not like resistance or combative, because we've had some of those situations happen with our population in the past. So like restraining them or trying, like to Jordana's point, it's a way for them to cope with what's happening because it's overwhelming. So I think just being cognizant of that is important.
Okay, so instead of putting, I don't know if combative movement is the best. Do we want to say energized movement, or how do we?
Yeah, I wouldn't say combative, but I'm more saying it for knowledge, like as an example of knowledge of how sometimes it can be misconstrued as combative. So I think portraying it in a way that is informative to ease those coming into it and working with these individuals have a better understanding of what those movements truly are and that they're not misconstrued, if that makes sense. So I think energized is fine, but
how about we, just saying that. So after the parentheses stimming, we, and not to be misconstrued with agitation.
yes, I think that would be helpful.
Okay. Okay, excellent. Thank you, guys. Is there anything else the group would like to add to this, or are we okay to move to the next slide? There are notes. So if we're good with this slide, if I can just get a thumbs up, thank you. Jordana, thank you. Dawn, thank you. Uthman, thank you. Okay, and Allison, thank you. Okay, excellent. So we'll go over the slide first and then the subset of words after. So neurodiverse children, if we can just review this text, make sure that it's not redundant for our providers in training and not overwhelming. I see a thumbs up from Doug that it looks good. Yes, Dr. Min?
Very minor grammar. In the second bullet, the second sentence asks if the patient or child uses headphones. There's just no period at the end of the sentence, and we're using periods throughout the rest of the slide.
Okay, I am not. You said the second bullet point?
Sorry, the second large bullet.
Thank you.
Yeah.
Thank you. Okay. All right, so I saw Doug had his thumbs up that this slide looked good to them. Thank you, Dr. Munn, for that feedback. And then Dr. Woolridge, I saw a thumbs up from you, Jordana as well, and Brian as well. Thank you. Okay, we're almost. So neurodiverse children, we have some information regarding behavioral health and de-escalation. I think maybe moving this to a second. Okay. Putting this to twice. Is there anything else that people see from this? The community org training for the children and youth with special health care needs program. Did we want to refrain from having this and just have it as a reference or a resource slide?
Sorry, Aubriana, you're talking specifically about the training?
Yeah.
The community org training?
Yes. Is that like Life Institute or is it?
No, it's the Preston's Pursuit of Acceptance. It's a nonprofit organization that offers training to first responders on better engaging with those with neurodiversity. So,
okay. So,
Dawn, is that organization, do they provide those services statewide or is it mostly?
Nope, they are expanding. They'll go statewide. So I know recently they did one up in Payson. So yeah, they've been trying to expand statewide.
Aubriana, it's in the notes for the slide underneath.
Okay. Oh, don't mind me, guys. Okay, thank you. Thank you, Jordana. Okay, so maybe I'll just put refer to Kristen's pursuit for acceptance. Does that work for the group? Okay.
Aubrey, and I think you could say something even more general, like that some community organizations provide training. Because we've got the Epilepsy Foundation there also specific to seizures. And then maybe just refer them to that resource slide for more information.
Okay.
Yeah, something like that.
Okay. Is there anything else from the group that they want to touch upon for this slide? No, Dr. Woolridge, I see no head. Can I get a thumbs up to move to the next slide? Okay, Doug, Brian, Dr. Woolridge, Dawn, Jordana, Allison, awesome. Okay, so future considerations. Okay, so prioritizing premise alerts is the first one. Polls. Do we need to spell that out for physicians? I mean, speaking for EMS providers. Okay, yes. Okay, thumbs up on that. Yes, Brian?
You were talking about spelling out POLST.
Yes.
There's probably a couple of different terms that come out of that, and at least in the state of Arizona, and I believe nationally now, except for maybe Oregon, the national organization has tried to make that simply POLST across the top and no longer spells out the different variations that people have come up with what that stands for.
Okay, so people should understand. Sorry, Brian, you put out on me. You said people should understand what that stands for.
What was that?
Your audio cut out on me. Did you say that people should understand what that stands for, so we don't need to?
Well, there's different variations across the United States of what that has meant, and the national organization has now simply put it as POLST on the top of the form without, and that's the way the national organization, is my understanding, has. See, that's got different meanings than that. That's the problem. And so they have now, it's supposed to be spelled out. It's just supposed to be POLST across the top without any of the states coming up with different kinds of things of what that means.
Okay, that's a good point. Thank you, Brian. So I agree. Oregon does do it differently. So I think we'll spell it out. Yes, Jordana?
Are we just saying that this slide is just going to for us to have further training on?
Yeah, this can be for further training. That's a good question. Do we want this to be for further training for them to focus on, or for this to just do their own independent research afterwards?
If we're going to do additional training, this was just like a highlight of what we want to get into, then I don't think we need to go into it. We can go into it once we develop more information on it, but so we don't have to be so specific about the name, but it depends on what we can do with it.
Okay. Thank you, Jordana. I think this is a good outlier for training that we could prioritize in the future. For children and youth with special health care needs, so I would say just leave it like this. But I'm happy to hear what the rest of the group thinks. Dr. Woolridge agrees with that. Okay, thank you. Is there anything else we want to have on here for children and youth with special health care needs that EMS should be considering? I'm going to put for nonverbal patients here, but okay. Hearing none, can I just get a thumbs up and we'll move forward to the next slide? Okay, Dr. Woolridge, Adam, Allison, Dawn, thank you. Okay, well, guys, we have done it. So we are on the resources. I'm going to just hyperlink Presence Pursuit for Acceptance and include everything else under here. Yeah, it's very exciting. So Dr. Woolridge, I'm going to kick it over to you to just have a celebratory send off.
Would there be benefit to doing these final edits, putting it all together in a single slide set, and giving this team a chance of one more look over, and really brief? I mean, like a 3-day deadline, Aubriana, before you take it forward.
Yeah, I think that would be great. And would we necessarily need to have a meeting to do this, or can we just do it over email and a group email?
I think just a group email so we can all have one last look at the final product, unless you guys don't feel we need that.
I like the sounds of a group email. I just want to make sure, Shelley, is that okay for any meetings with rules or anything, or rules for meetings?
I think, yeah, we're also going to take edits, suggestions during the meeting, so it's fine.
Great. Wow. Wonderful, wonderful job, Aubriana. Thank you so much for organizing all of us and getting us all together. Shelley, for all your work too.
Couldn't do it without all of you guys. So thank you all so much, especially Dawn and Jordana and Allison, who presented this idea in the first place. So really appreciate everyone dedicating their time and all of their efforts. This is amazing. So thank you guys.
All right. Well, meeting adjourned.
Awesome.
Thanks, everybody.
Thank you. Bye.
Thank you.